Assalamualaikum warahmatullahi wabarakatuh. Greetings to everyone. It's a pleasure to meet everyone here, although only virtually and asynchronously. I hope that everyone is in good health. In this lecture, I will discuss about the role of radiotherapy in cancer treatment. Radiotherapy is a treatment modality using ionizing rays or high-speed particles. Ionizing rays is a part of the electromagnetic spectrum wave with a certain wavelength. When this energy passes through a biological matter, it will produce an ionizing effect which can result in cell death. I believe you have all finished our first session of the lecture. Now we will continue with our second session, where we will discuss about milestones of radiation oncology discipline as an implementation of scientific and technological advancement, especially computers in radiation oncology. Radiation oncology development is tightly in line with diagnostic radiology. When they started 2D imaging, we also started conventional 2D radiotherapy. When the era of 3D imaging started, using CT scans and MRIs, we also started using conventional 3D radiotherapy, followed by intensity modulated radiotherapy or IMRT, and also tomotherapy. 4D advanced imaging is also closely followed by 4D radiotherapy. Diagnostic radiology is more in charge of finding the radiation target, which is the cancer in human body. For example, look at this old man sculpture in the upper right corner here. The role of radiation oncology is to shape the radiation beam to be exactly like the target found by diagnostic radiology procedures. This is made possible by a technique called intensity modulated radiotherapy or IMRD. And we also have to do the best dose painting, which is to adapt our radiation dose with findings from theranostic imaging when available, which is a biological imaging modality showing heterogeneous biological behaviors of a tumor as our target. We also have to manage problems with internal movements, for example, because of respiration, intestinal movements, and also to adjust our radiation delivery so that it will be precisely placed as our planned sculpture with image-guided radiotherapy or IGRT technique. Schematically shown here, if we are doing 2D radiotherapy, then the radiation delivered will be in the form of this hexagonal cube here, for example. The actual target is actually only the moving blue part. Therefore, other than that, normal tissue surrounding it in the cube will also get irradiated with the same dose as a target. Now with 3D methods, the portion of normal tissue surrounding the target can be reduced in a shape of a tube or an egg. And if we use IMRT, then the radiation beam can be shaped according to the target's shape. All the target's curves can be followed. However, there still need to be margins around it to anticipate internal movements inside our body, such as respiratory movements or intestinal movements. Even more advanced, with IGRT, the margin sparing can be further reduced, and the final result of using advanced technology is that we will be able to protect more normal tissues from radiation exposure in curative doses. This is an example of 2D conventional radiotherapy. All the tissue in the blue box, including the target and the normal tissue around it, will get the same radiation dose. With 3D conformal radiotherapy, we use 3D imaging in planning the radiation treatment. Therefore, it will be clearer where is our radiation target, and the radiation beam can then be focused to that area. By using IMRT, radiation with modulated intensity and collimator shapes from different directions are delivered. Hence, we can get a dose distribution like shown here. In the picture on our right hand side, the above picture shows a radiation dose distribution focused to the target area. In the picture below it, you can see that the radiation is actually given from so many directions to get such dose distribution curve. Now, if we are using only 2D conventional radiotherapy, such as shown in the picture in our left-hand side, radiation is given only from 2 directions or maximally from 4 directions. Now, these color wash images show how dose is distributed in the planning. The darker color represents higher curative doses, while the lighter ones represents lower dose of radiation. The left-hand side picture is a 2D distribution dose, which is showing that the dark brown colored area is the part which get the dose that we planned, and is much more than the intensity modulated plan shown in the right-hand side picture, where the curative dose planned would only hit the targeted radiation area. This is another example of the difference of treatment plannings using 2D, 3D, and MRT techniques in a patient with the same target. The target actually is colored purple here. Now, when we do 2D radiation, the blue colored area will get radiation with the same dose of the target. With 3D, this area became smaller, which means that normal tissue affected will be smaller. However, with intensity modulated radiotherapy technique or IMRD, the result will be further enhanced, whereas the area that will get the planned dose is exactly the target. In other words, a better therapeutic ratio will be achieved, meaning that with the same dose we will get a maximum impact to tumors while getting a very minimum effect to normal tissues. How is the dose distribution of radiation for breast cancer, as it is the cancer with the highest incidence in Indonesia? In this treatment, we need to protect the lungs and the heart from unwanted exposure of radiation or exceeding the dose threshold allowed by international standard, which is called as maximum tolerance dose. We see here that the dose is distributed very well, where the lung will not get unwanted radiation exposure, because the exposure can be modulated in such ways to protect the lung with recent technologies. Stereotactic radiosurgery, or SRS, is a radiation procedure given in a single time using very high dose. So it needs to be delivered in very high accuracy and precision. In the past, we deliver this SRS technique using a rigid frame called a Lexel G frame, as shown here, as an immobilization device screwed to the skull to make sure that there will be no patient movement during radiation delivery. Nowadays, we no longer need to screw such frame to patients' heads anymore. The function is replaced by a special flexible frame with accuracy level similar with a Lexel G frame, and it is completely non-invasive to the patient. And because it is non-invasive, it is easier to do it in fractionation or divided dose, called as stereotactic radiotherapy. This technique is employed especially when the target is very close to organs at risk. These two techniques are usually given to small lesions, slow-growing tumor types, or vascular malformations in the brain, such as the AVM. In Indonesia, these advanced stereotactic radiation techniques are only available in RSCM, in the Radiation Oncology Department, since 2008 up until now. The biological effect of SRS in cell killing is different than those of conventional radiation. Aligned with its name, this procedure is expected to achieve similar result with surgery, with the advantage that it can be done to locations difficult to be reached even by surgery. A similar procedure can also be done in the body, known as the stereotactic body radiotherapy, or the SB-RT, with a different immobilization device, which is the vacuum blue bag. This blue bag also ensures that there will be no patient movement. This technique is also delivered with high dose in each fraction. Unlike the conventional radiation, which is usually given in 20 to 35 fractions, SBRT can be completed in no more than 10 fractions. SBRT is given, for example, to hepatoma cases, prostate cancers, and also for partial irradiation of the corpus vertebrae in bone metastasis cases. Repeating again, one of the most important things in radiotherapy is the therapeutic ratio. To achieve an ideal therapeutic ratio, several approaches from physics or biological aspects can be done. This is the image of the physics aspect approaches. We can try to do dose sculpting or sculpting the beam to conform with the target form using 4D imaging and using good immobilization techniques such as what we employ for stereotactic radiation. A more recent advancement of the IMRT technique is called volumetric modulated arc therapy or VMAT, where a radiation is delivered using a continuously rotating gantry. Even though that the dose distribution and conformity index is not significantly different, the radiation can be delivered much faster. This time factor is important to increase accuracy of radiation. The development of LINX, linear accelerators, or machines producing X-rays or electrons from electricity, has launched the next generation of LINX, which is known as the O-LINX. The shape is very similar to CT scans, where gantry and the verification tools are all placed inside the O circle. There are two O-LINX available right now in the market, which are the Halcyon, which is simpler, and tomotherapy. Both of them are available in our radiation oncology department in RSCM. This is one of our treatment planning results from our tomotherapy machine, which is capable to produce a remarkable dose distribution. For example, in the left-hand side, the upper image, to irradiate whole brain, such as in brain metastasis cases, we can protect the hippocampus from radiation exposure because hippocampus has a very important function to maintain the patient's quality of life. The images below is another example showing that we can do a whole cranial irradiation, for example, in cranial metastasis cases, and we can avoid giving high radiation dose to the brain tissue inside. This is how the tomotherapy machine looks like, the only one in Indonesia, which is in Radiation Oncology Department of RSCM FKUI. We also added an LCD screen on the ceiling so that the patient will be more comfortable during the treatment. This is especially important when we treat children, so they can watch their favorite videos during their radiation session. This is an example of dose distribution when we do total skin irradiation by tomotherapy, something that is nearly impossible to do if we use other types of LINX. You can see here, usually it is given for mycosis fungoides, which is skin lymphoma. This is where we do craniospinal irradiation for medulloblastoma cases in children, for example, where we need to irradiate all the cerebrospinal fluid from head until the level of second lumbar vertebrae. Because of limitation in field sizes of conventional LINX, usually we need to divide the radiation field into several parts, which requires junctions between them. Now, junctions are not ideal because there might be hot spots or cold spots in them. This limitation, fortunately, can be overcome by tomotherapy because there is no limit of field size that we can use. Another example is when we do whole abdomen irradiation for cases like pediatric nephroblastoma. We can protect the healthy kidney from unwanted radiation exposure with tomotherapy. Now, let's see the whole process of radiation therapy. It begins with physical examination and all data collecting from the patient, and we decide if there is any indication for radiotherapy. If there is, what is the target, what is the dose, and by which technique we need to do it, which should be the best for the patient. Then, the patient will move to what we call a mold room, where all immobilization devices needed will be made, such as masks or blue bags. Next, the patient will go to the CT simulator room, where CT scans will be done on the tumor and surrounding tissues to decide on the radiation target. On the CT simulator session, all immobilization devices must already be used on the patient. Then, the CT scan images will be sent to the treatment planning room. We will delineate which area that needs to be irradiated as the target and which area need to be protected from radiation as organs at risk. Next, treatment planning will be done by a medical physicist, and this planning will be analyzed and approved by the doctor, the radiation oncologist. Is the dose maximally delivered to the target with as minimal dose as possible to areas which need to be protected? These are some key questions that need to be analyzed during verification. Then, the patient will be sent to the treatment room, where verification of the treatment planning will be done before the radiation is given. Verification can be given in 2D method called EPIT or 3D by cone beam, based on the radiotherapy technique planned. And after everything is checked in accordance, then and only then radiation can be given. You can see here that many personnels play a role in the radiotherapy journey, from a nurse, radiographer, a medical physicist, and the radiation oncologist herself. In delivering radiotherapy services, besides the main modality of linear accelerators or cobalt machines, many supporting modalities are required, such as CT simulators or conventional simulators, and also the treatment planning system softwares. Another required tool, which is as important, is dosimetry tools, which can measure the radiation output of the main modality or the linacs. When a dose of 2 gray, for example, is prescribed, is it true that 2 gray was actually produced by the machine? This has to be routinely measured daily, weekly, monthly, 3-monthly, 6-monthly, annually, and these results will be verified by Batan. And this data will be the consideration for Bapeten as our national regulatory body for nuclear utilizing institution to issue the license of radiotherapy unit utilization. As a summary, up until now, the evolution of radiotherapy in the last 30 years include: first, how we can shape the radiation beam in accordance to the target shape that we want, how to precisely deliver it to the target while protecting the surrounding normal tissues from radiation exposure as much as possible. Secondly, the most recent development is the use of proton or other particles in radiotherapy, which will be explained later. Now, back to the radiotherapy process. First, we find and localize the target with CT simulator, and then we determine the target delineation and also the organs at risk, continued with treatment planning. Okay, so now when the radiation is already shaped according to the target, where should the radiation beam be directed? Of course, to the target, but how? How can we be precise? Therefore, it is required to do verification procedure in the radiation treatment rooms, whether by 2D technique with tools known as EPIT, electronic portal imaging device, or by 3D with CT scan built in the radiotherapy machine. After the target position is confirmed with what is planned, with a margin of error of only 1 millimeter, only then radiation can be given. This is done every day until the prescribed dose according to plan is received. For conventional radiotherapy, it will be given in around 20 to 35 times according to the cancer type and status. And for stereotactic techniques, it is delivered in 1 fraction for SRS and up to 10 fractions for SRT or SBRT. We have discussed about verification procedure in radiotherapy before radiation is delivered. This is the tools. So the yellow beam going from above to bottom, this is what we call EPID, or electronic portal imaging device, which is a 2D verification tool. While the ones placed on either side of the patient, left and right of the patient, which makes the tool has 4 arms, is what we call as con-beam CT. So we will have 2 CT imaging, the CT planning results and the verification CT. These 2 CT images has to be fused and they need to be in accordance with each other with accuracy level below 1 millimeter. Now we will move to talk about PET-CT as a biological imaging modality or theranostics as part of radiotherapy planning. This is available in one private hospital in Jakarta where PET-CT is used in place of CT simulator, so that by using FDG contrast, which consists of glucose, it will be uptaked by all living biological matter. And from the degree of the uptake, we can determine more precisely our radiation target. The blue image shown here is a PET-CT image. The red one is the contrast showing the bladder, but please note the structure above it. The small light blue structure is actually a tumor shown by the FDG contrast uptake in that area. Now we will move on to 4D radiotherapy, which is made possible by using 4D CT imaging, 4D treatment planning, and of course 4D treatment delivery. For example, is by using Linux equipped with active breathing control system, so that we can track the internal movement during radiation treatment delivery. So 4D radiotherapy is how we can manage the problem coming from internal movement of organs in the human body. For example, due to respiratory or intestinal movement. This is the purpose of 4D radiotherapy. There are a few ways to control those movements. First is direct tumor imaging, which is imaging that is taken continuously during the radiation treatment. This is limited by the consideration of how much dose will be received totally by the patient by this approach. Secondly, by using an internal surrogate, which is placing a marker inside the target. The downside of this is that, of course, it is invasive. Now the last approach is we can use external surrogates, and this is most commonly used. This is an example of 4D CT use, which will be integrated for 4D radiotherapy. You can see at our right hand side on the bottom of the screen, the green circle is where the radiation target at. So if we put into account the movement, then we need to enlarge the circle to make sure that the tumor is always irradiated during movement. Now compared to the images next to it, please see, is the next one next to it is when we do gating system, which means that the radiation beam will be on only when the target enter the field. And also compared with the tracking system on the far right, where the beam will follow the movement of the target. The two most commonly used techniques are the gating system, being on and off, aligned with inspiration and expiration. The radiation will be on while the patient is exhaling deeply. Or The breath hold technique is where the radiation will be on when the patient is holding his breath, typically around 20 seconds. Now we have come across protons. What is proton? Proton is an ionizing particle with a mass of 1, seen in this picture here. Proton has a certain radiophysics characteristics so that we can see the implementation shown in this image. The one on our left-hand side is the dose distribution of proton. We can see that even though there's still entrance dose, but note that there is no exit dose here compared to the image next to it is after photon conventional radiation therapy, there is exit dose below the tumor. This is the percentage depth dose of a proton. The proton curve is the red one compared to the curves of photons and electrons shown by the black curves on the graph. You can see that the proton curve showed the peak dose happen inside in the target area, and then the dose will rapidly decrease to 0. The isodose curve comparison between a proton planning and a photon, you can see here. You can see that the normal tissue radiated in low dose is lower significantly by using proton. However, the limiting factor for usage is that proton machine price is very, very expensive. Right now it's about 10 times the price of a very good quality Linux. Now let's move on to brachytherapy. As we have mentioned in session 1, it is divided into contact brachytherapy, which is placing the radiation source closer to the target, like seen on the pictures above, number 1 and 2, and the third picture below it. It shows mold brachytherapy in the oral cavity, intracavitary brachytherapy for cervical cancer, and nasopharyngeal brachytherapy. Meanwhile, the other 4 pictures below them are pictures of interstitial brachytherapy, where radiation sources are inserted through needles to the target area. All of this, in principle, is to place the radiation source closer to the target. We do it by inserting the applicator, and then the patient will enter the radiation room, and then the radiation source will be inserted through the applicators. That is why this technique that we use now is called afterloading brachytherapy. Just like external irradiation, brachytherapy can also be done in 2D verification techniques by using a C-arm. This image is showing the radiographic image of the applicator's position in a cervical cancer case brachytherapy. Or using a 3D technique where we do verification using a CT scan. Schematically, the dose distribution of brachytherapy is actually similar to those of proton, which results in the reduction of the portion of normal tissue that gets irradiated. Why as many technological advancement needs to be continually pursued, it is written clearly in this paper. We need to keep reducing the exposure of organs at risk, which actually does not need to get exposed to any irradiation. We can see in the graphics here, the above one is that there are significant reduction of radiation exposure to small intestines, and the one below shows it's for the bladder when we do radiation in the pelvic area with more advanced technologies. Also seen in this table showing late side effects of radiation. Here it is showing the rate of xerostomia after head and neck cancer radiation. There is significant reduction of this when we use more advanced techniques of radiation. Finally, here I would like to show schematically how radiation works in combination with chemotherapy when given simultaneously as chemosensitizer. It can work in supra-additive or sub-additive function. Supra-additive is when there is increase in effects, while sub-additive is when there will be inhibition of effects. They can work spatially, which is working in different pathways. For example, that chemo works systemically to control micrometastasis, while radiation works mostly locally. Or they can work together in synergy. if they are working through the same biological pathway. For example, we give taxane drugs at the same time with radiation, where taxane is a chemotherapy drug which works by blocking the cell cycle in G2 and M. These cycles, G2 and M, are the most sensitive cycles to radiation. Therefore, when given together, there will be enhancement effect of the chemo, and more especially the radiation effect. So we have finished our second session of the lecture, which have included the role of radiation in cancer treatment. For those interested to learn more, you can continue to the third session on how to ensure quality and safety in radiotherapy, as we have already mentioned that radiation has no smell, no taste, no color. How can we ensure that radiation is actually given as we planned? And we will also discuss there the current profile of radiotherapy in Indonesia. So thank you. Wassalamualaikum warahmatullahi wabarakatuh.